Today we are going to discuss about lung and thorax examination.
Hi,
We
I'm
will start
Priya
examination
from
through
OSCE.
posterior
Today
chest.
I'm going to examine your chest and thorax. Is that okay with you?
Okay.
So do you have any problem breathing?
No.
Okay.
Examine the posterior
We are
thorax
going
and
to
lungs while the
examine
patient is
your
sitting.
thorax.
The patient's arms should be folded across the chest with hands resting, if possible, on the opposite shoulders. This position swings the scapulae laterally and increases access to the lung fields. Start the examination of posterior chest with inspection. Standing in a midline position behind the patient, note the shape of the chest and how the chest moves. Include the following: deformities or asymmetry in chest expansion, abnormal muscle retraction of the intercostal spaces during inspiration and most visible in the lower costal spaces. Impaired respiratory movement on one or both sides or a unilateral lag or delay in movement. Asymmetry expansion occurs in large pleural effusions. Retraction occurs in severe asthma, COPD, or upper airway obstructions. Unilateral impairment or lagging suggest pleural diseases from asbestosis or silicosis. It is also seen in phrenic nerve damage or trauma. Palpation. As you palpate the chest, focus on areas of tenderness or bruising, respiratory expansion, and fremitus. Identify tender areas. Carefully palpate any area where the patient reports pain or has visible lesions or bruises. Note any palpable crepitus defined as a crackling or grinding sound over bones, joints, or skin with or without pain due to air in the subcutaneous tissue. Crepitus may be palpable in overt fractures and arthritis joints. Crepitus and chest wall edema are seen in mediasthenesis. Access any skin abnormalities such as masses or sinus tracts, blind, inflammatory, tube-like structures opening onto the skin. Test checks expansion. Place your thumbs at above the level of the 10th rib with your fingers loosely grasping and parallel to the lateral rib cage. As you position your hands, slide them medially just enough to raise a loose fold of skin between your thumbs over the spine. Ask the patient to inhale deeply. Watch the distance between your thumbs as they move apart during inspiration and feel for the range and symmetry of the ribcage as it expands and contracts. This movement is sometimes called lung excursion. Unilateral decrease or delay in chest expansion occurs in chronic fibrosis of the underlying lung or pleura, pleural effusion, lobar pneumonia, pleural pain with associated splinting, unilateral bronchial obstruction, and paralysis of the hemidiaphragm. Palpate both lungs for symmetric tactile fremitus. Fremitus refer to the palpable vibrations that are transmitted through the bronchopulmonary tree to the chest wall as the patient is speaking and is normally symmetric. Fremitus is typically more prominent in the intrascapular area than in the lower lung fields and is easier to detect over the right lung than the left. It disappears below the diaphragm. To detect fremitus, use either the ball, the bony part of the palm at the base of the fingers, or the ulnar surface of your hand to optimize the vibratory sensitivity of the bones in your hand. Ask the patient to repeat the words 99 or 111. Use both hands to palpate and compare symmetric areas of the lungs in the pattern shown. Identify and locate any areas of increased, decreased, or absent fremitus. If fremitus is faint, ask the patient to speak more loudly or in a deeper voice. Tactile fremitus is somewhat imprecise assessment technique, but does directly your attention to possible asymmetrics. Fremitus is decreased or absent when the voice is higher pitched or soft, or when the transmission of vibrations from the larynx to the surface of the chest is impeded by a thick chest wall and obstructed bronchus, COPD, or pleural effusion, fibrosis, air, or an inflammatory tumor. Percussion. Percussion is one of the most important techniques of physical examination. Percussion sets the chest wall and underlying tissues in motion, producing audible sound and palpable vibrations. Percussion helps you establish whether the underlying tissues are air filled, fluid filled, or consolidated. The percussion blows penetrates only 5 to 7 centimeters into the chest, however, and will not aid in detection of deep-seated lesions. Hyperextend the middle finger of your left hand, known as the pleximeter finger. Press it distal interphalangeal joint firmly on the lung surface to be percussed. Avoid surface contact by any other part of the hand because this dampens out the vibrations. Note that the thumb and the second, fourth, and fifth fingers are not touching the chest wall. Position your right forearm quite closely to the surface with the hand cocked upward. The middle finger should be partially flexed, relaxed, and poised to strike. With a quick, sharp but relaxed wrist motion, strike the pleximeter finger with the right middle finger called the flexor finger. Aim at your distal interphalangeal joint. Strike using the tip of the flexor finger, not the finger pad. The striking finger should be almost at right angles to the pleximeter. A short fingernail is recommended to avoid injuring your knuckle. Withdraw your striking finger quickly to avoid dampening the vibrations you have created. While the patient keeps both arms crossed in front of the chest, percuss the thorax in symmetric locations on each side of the apex to the base. Percuss one side of the chest and then the other at each level in a ladder-like pattern. Omit the areas over the scapulae. The thickness of the muscle and bone alters the percussion notes over the lungs. Identify and locate the area and quality of any abnormal percussion note. Identify the descent of the diaphragm or diaphragmatic excursion. First, determine the level of diaphragmatic dullness during quiet respiration. Holding the pleximeter finger above and parallel to the expected level of dullness, percuss downward in progressive steps until dullness clearly replaces resonance. Confirm this level of change by percussing downward from adjacent areas, both medially and laterally. Dullness replaces resonance when fluid or solid tissue replaces air containing lungs or occupies the pleural space beneath your percussing fingers. Lobar pneumonia, in which the alveoli are filled with fluid and blood cells, is an example. Auscultation. Auscultation is the most important examination technique for assessing air flow through the tracheobronchial tree. Auscultation involves listening to the sounds generated by breathing, listening for any adventitious or added sounds, and if abnormalities are suspected, listening to the sounds of the patient's spoken or whispered voice as they are transmitted to the chest wall. Before beginning auscultation, ask the patient to cough once or twice to clear mild atelectasis or airway mucus that can produce unimportant extra sounds. Listen to the breath sounds with the diaphragm of your stethoscope after instructing the patient to breathe deeply through an open mouth. Always place the stethoscope directly on the skin. Clothing alters the characteristics of the breath sounds and can introduce friction and added sounds. Air movement through a partially obstructed nose or nasopharynx can also introduce abnormal sounds. Use the ladder pattern suggested for percussion, moving from one side to the other and comparing symmetric areas of the lungs. Listen to at least one full breath in each location. If you hear or suspect abnormal sound, auscultate adjacent areas to assess the extent of any abnormality. If the patient becomes lightheaded from hypoventilation, allow the patient to take a few normal breaths. Note the intensity of the breath sounds, which reflects the airflow rate at the mouth and may vary from one area to another. Breath sounds are usually louder in the lower posterior lung fields. If the breath sound seems faint, ask the patient to breathe more deeply. Shallow breathing or a thick chest wall can both alter breath sound intensity. Breath sounds may be decreased when airflow is decreased or when the transmission of sound is pure, as in pleural effusion, pneumothorax, or COPD. Listen for the pitch, intensity, and duration of the inspiratory and expiratory sounds. In cold or tense patients, watch for muscle contraction sounds, muffled, low pitched rumbling, or roaring noises. Adventitious sounds. Listen for any added or adventitious sounds that are superimposed on the usual breath sounds. Detection of adventitious sounds like crackles, wheezes, and bronchi is an important focus of your examination, often leading to diagnosis of cardiac and pulmonary conditions. The most common adventitious sound are crackles, loudness, pitch, and duration summarized as fine or coarse crackles. Number few to many. Timing in the respiratory cycle. Location on the chest wall. Persistent of their pattern from breath to breath. Any change after a cough or change in the patient's position are the clues to identify crackles. The crackles of heart failure are usually best heard in the posterior inferior lung fields. Clearing of crackles, wheezes, or bronchi after coughing or position change suggest inspissated secretions seen in bronchitis or atelectasis. Transmitted voice sounds. If you hear abnormally located bronchovesicular or bronchi breath sounds, access transmitted voice sounds using three techniques. Listen in symmetric areas over the chest wall for abnormal vocal resonances suspicious for pneumonia or pleural effusion. First is egophony. Ask the patient to say E. You will normally hear a muffled long E sound. If E sounds like A and has a nasal bleating quality, an E to A change or egophony is present. Bronchophony. Ask the patient to say 99. Normally, the sounds transmitted through the chest wall are muffled and indistinct. Louder voice sounds are called bronchophony. Localized bronchophony and egophony are seen in lobar consolidation or from pneumonia. Whispered pectoriloquy. Ask the patient to whisper 99 or 123. The whispered voice is normally heard faintly and indistinctly, if at all. Louder, clearer, whispered sounds are called whispered pectoriloquy. Examination of the anterior chest. Anterior chest should be examined when the patient is lying in supine position. The patient should lie comfortably with arms somewhat abducted. If the patient is having difficulty breathing, raise the head of the examination table or the bed to increase respiratory excursion and ease of breathing. Inspection of anterior chest. Observe the shape of the patient's chest and the movement of the chest wall. Note any deformities or asymmetry of the thorax, abnormal retraction of the lower intercostal spaces during inspiration or any supraclavicular retraction. Local lag or impairment in respiratory movements. Abnormal retraction occurs in severe asthma, COPD, or upper airway obstructions. Palpation. Palpate the anterior chest wall for the following purposes: identification of tender areas, assessment of bruising, sinus tracts, or other skin changes, assessment of chest expansion. Place your thumb along each costal margin, your hands along the lateral rib cage. As you position your hands, slide them medially a bit to raise loose skin folds between your thumbs. Ask the patient to inhale deeply. Observe how far your thumbs diverge as the thorax expands and feel for the extent and symmetry of respiratory movement. Tender pectoral muscles or costal cartilages suggest, but not prove, that chest pain has a localized musculoskeletal origin. Assessment of tactile fremitus. If needed, compare both sides of the chest using the ball or ulnar surface of your hand. Fremitus is usually decreased or absent over the precordium. When examining a woman, gently displace the breast as necessary. Percussion of anterior chest. As needed, percuss the anterior and lateral chest again, comparing both sides. The heart normally produces an area of dullness to the left of the sternum from the third to the fifth interspaces. To enhance percussion, gently displace the breast with your left hand while percussing with the right, or ask the patient to move the breast for you in a woman. Identify or locate any area with an abnormal percussion note. Percuss for liver dullness and gastric tympani. With your pleximeter finger above and parallel to the expected upper border of liver dullness, percuss in progressive steps downwards in the right midclavicular line. Identify the upper border of liver dullness. Lateral during the abdominal examination, you will use this method to estimate the size of the liver. The dullness of right middle lobe pneumonia typically occurs behind the right breast. Auscultation. Listen to the chest anteriorly and laterally as the patient breathes with mouth open and somewhat more deeply than normal. Compare symmetric areas of the lungs using the pattern suggested for percussion and extending it to adjacent areas. If indicated, Listen to the breath sounds, noting their intensity and identifying any variations from normal vascular breathing. Breath sounds are usually louder in the upper anterior lung fields. Bronchovesicular breath sounds may be heard over the large airways, especially on the right. Identify any adventitious sounds. Time them in the respiratory cycle and locate them on the chest wall. If indicated, listen for transmitted voice sounds.